everybody. Welcome to the third episode of the Progress Profile Alzheimer's Research in Focus, a podcast series featuring conversations with the world's leading Alzheimer's experts. My name is Lindsay Simas. I'm a licensed clinical psychologist and director of business development for Pearson Clinical Assessment's Pharmaceutical Division. In our first episode, we explored current Alzheimer's research and potential causes and promising treatments with Dr. Jeffrey Cummings. In our second episode, we examined the amyloid hypothesis with Dr. Philip Sheltons. Today, we turn to a central question. Are individuals predisposed to Alzheimer's through genetics, or are the causes primarily environmental and lifestyle related? Guiding the discussion is our moderator, Dr. John Harrison. Dr. Harrison is joined by the distinguished Dr. Miia Kivipelto. Dr. Kivipelto is a Finnish neuroscientist and professor specializing in dementia and Alzheimer's disease. Her research focuses on the epidemiology, prevention, and treatment of dementia, especially in relation to vascular and general health risk factors like high blood pressure, physical fitness, and obesity. Dr. Kivipelto's research includes the landmark Finnish geriatric intervention study to prevent cognitive impairment and disability, also known as the FINGER trial, which showed how diet, exercise, and cognitive training can help preserve cognitive function in high-risk older adults. Today, she leads the worldwide FINGERS initiative, advancing dementia prevention efforts across the globe. And now I'll hand it over to Dr. Harrison to get us started.
Thank you for that wonderful introduction, Lindsay. And today I'm delighted to be joined by Dr. Miia Kivipelto. Miia, let's begin the discussion. The FINGER study is very much part of your career and much of the success you've achieved. So I think the best place to start is for you to give us a brief overview of the FINGER study and its components. And I'd be particularly keen to know how you managed to retain your study participants.
Thank you, John. And indeed, there has been a huge development in the field of dementia prevention and risk reduction. We know now that 45% of all dementias are linked to modifiable risk factors. And just to give a reflection, when I started my research career more than 25 years ago, it was only high age and genetics. These were the established risk factors. So there was not so much what we could do. And now, as said, 45% throughout the whole life course, lifestyle, vascular, metabolic, environmental risk factors. And that's why we normally say it's never too early to start to prevent this type of cognitive impairment. So FINGER trial, it was the first randomized control trial in the whole world to really show that it is possible to improve cognitive performance and reduce the risk of cognitive decline. We started the trial 2009, and what we did was we put together different modifiable risk factors. So the FINGER model is actually easy to remember because it's like one hand and five fingers. We have first the healthy diet. That's very important for the brain health. We know that the brain needs nutrients and vitamins throughout the whole life course. The second finger is physical activity. And I would say that that's one of the most powerful medications what we have. We know now that only 10 minutes of physical activity every day can affect more than 10,000 molecules, which are important for the brain health. So it's really important to be physically active. Every step counts. And that, I would say, is so important in our sedentary societies. The third finger is cognitive training or mental activities. And I would say that the brain is like our muscles. We need to train our brains throughout the whole life course. Fourth finger is the social activities, stress management, and sleep. And again, in our hectic societies, these are important risk factors, especially the stress management, sleep. We also know that loneliness and hopelessness are increasing, even among younger populations. And then the fifth finger, the last finger, Is taking care of all cardiovascular metabolic risk factors like blood pressure, cholesterol, diabetes, or obesity. So we can say what is good for the heart is also good for the brain. So what we did, the finger group got all these 5 fingers, activate all your 5 fingers every day for 2 years. And what we saw was that the finger group had better memory, better cognitive function, and even many other positive outcomes. So that was really wonderful to see. So these are mainly the main results from the finger study.
Mia, thank you so much. And that's a great place to start. And I think some of the extra evidence that you were able to present to us at the AAIC meeting in Toronto was even more compelling. So a real success story. And I think you and your colleagues must be complimented on what you've achieved so far. And I'm mindful of the fact that that's quite a lot of information that you're imparting to your study participants. And a key element of our success in research is managing to bring people with us. Did you do anything special in the finger study to keep people in? What was your approach to keeping people engaged?
That's a very good question. And we all know that it may be possible to keep the healthier lifestyle for a few weeks, but here we are talking about 2 years.
Right.
So what we did was really having the positive attitude, empowerment of own health, motivation, starting with small steps. So, for example, we started the whole intervention with healthy diet. Then we added physical activity and then cognitive training. So not doing everything at once. So I would say that these are really, really the key factors. And what we could see was indeed that those individuals who had better adherence had also better cognition still after 11 years. These are the new results I presented at AAIC. So the intervention was 2 years, but now we can tell that if you manage to have the higher adherence, you still can see the results after 11 years. And you reminded me about the US pointer. Indeed, this has been the question. We have the finger trial in the Nordic countries, how that model works globally. So we started the Worldwide Fingers Network 2017 because there was a huge interest globally after we published the finger in the Lancet 2015. Now we have 70 countries from all the continents who are part of the Worldwide Fingers Network. And US Pointer, the finger trial in the US, is one of the largest trial part of the Worldwide Fingers Network. And the results presented at AAIC in July were almost identical with the finger results, meaning that this model works and can be adapted to different populations. So that was wonderful, wonderful moment being there.
And it was wonderful to be there to share that, because I think in an age where we want to encourage people to do things, there's always the search for evidence. And so much of what we've shared historically has been anecdotal. So, it was a talking point of the conference. So, so nice to hear that data. And again, congratulations to you and your team.
Thank you.
You're very welcome. There's one other element to this I was keen to get your view on, Miia, if I might. So in my experience of talking publicly about Alzheimer's disease and dementia prevention, which happily that there is, I think, an increased interest. So that's very encouraging. But much of what I say, even to fairly well-educated, often intelligent, motivated audiences, seems to be new information for them. Was that your experience in the finger studies when engaging with your study participants?
Indeed, yes. I mean, when we started the finger trial, people were quite skeptical. Can lifestyle really work? And especially because it has been so difficult to find any pharmacological interventions. So this was the starting point, but we did not give up. And I think for me, it makes sense that the prevention and modifiable risk factors are important because they are important also for many other chronic diseases. Let's say stroke, diabetes, cardiovascular diseases, even cancer. So in that way, many of the modifiable risk factors are indeed similar. When we started the Worldwide Fingers Network, and we have now started to see the results, not only from the original finger study, now we have US Pointer, we have a trial from Australia, from Malaysia, from Japan. So we really are having a stronger evidence base to say that you can reduce the risk. There are evidence from randomized trials. One challenge in our field has been also that the definition of lifestyle interventions has been quite different in different trials. And in that way, it has been not as easy to collect really the results. It has been quite mixed results. And that's why when we started the Worldwide Fingers Network, one goal was try to harmonize the research methodology and also try to share the data so that we can really get even stronger evidence base. So I think now we are in a very different position what we were when we started the finger. But I agree, we still need to do so much to increase the awareness, both among clinical people who work in the healthcare systems, but also the general audience.
That's really helpful and fantastic that this is now such a worldwide endeavor. That's such a nice development, particularly off the back of the positive data you've previously reported. There's one other element to this I was keen to ask of you, and it's really about your personal experience of dealing with people who are either living with or at risk of dementia, and particularly Alzheimer's disease. So lots of the conversations we have with people in the context of their genetic predisposition. And I wondered, is there a different course of prevention or treatment that you would advocate for people who are E4 homozygous, for example? Or can you prescribe a sort of one-size-fits-all model?
This is a great question. And actually, already before we started the finger trial, we had decided that we want to study the gene environmental interactions and analyze if the effect of the multi-domain lifestyle intervention differs if you have APOE4 or if you don't have APOE4. And very interestingly, it seems that APOE4 carriers are getting more clear benefit for cognition from this multi-domain lifestyle intervention. And again, we have totally new results when we put together data from the fingers trial, the trial in Japan and France, meta-analysis which we presented at AAIC, confirming these results. APOE4 carriers are getting more clear benefit. And I think this is a wonderful news because we can't change our genes, but we can try to minimize the effect, the negative effect of the genetic factors. So I see APOE4 carriers as a very important target group for the multi-domain interventions. And this is also reflecting the fact that the new anti-amyloid treatments may have and seems to have bit more side effects if you have APOE4. So clearly these individuals need some other type of interventions as well. Your questions about APOE4 homozygous, the answer is we don't know yet because that group is still so small that we have not had the power to analyze that. But I'm optimistic that giving the worldwide fingers with more than 20,000 participants already in the completed trials, this will happen in the close future.
Excellent. We'll watch this space, Miia, for you and your worldwide fingers trial colleagues. So thank you for that. And it does suggest, doesn't it, that the genetic screening should be at least part of our offering. And I suppose that begs the issue, if people accept genetic screening, there's presumably then a conversation to be had with them about managing their expectations and also probably around data privacy as well. How do you manage that in the finger studies?
That's a great question and complex question as well as you said. Genetic testing has many implications on the individual level, but also for the families, the privacy. So in that way, there have been a bit different opinions how we should start using that test. I would say that we know that APOE4 is quite common in the general population. Between 15 to 25% of the population have at least one APOE4 genotype, so it's quite common. And we know that it's probably the most important genetic risk factor for Alzheimer's disease. However, many people who have APOE4 will never develop Alzheimer, and you can get Alzheimer without APOE4. So when and if we start testing, it's very important to give the information in right way so that the individual understands the consequences. And also the difference between the mutations, which are very rare, less than 1% of all Alzheimer patients have the familial Alzheimer's disease. But this difference and understanding that, I think, is very, very important. And I would like to see it more that the genetic information is part of the package, that you have your modifiable risk factors. We know, for example, that if you have high blood pressure or obesity or diabetes, each of these individual modifiable risk factors can also increase your risk around the same amount than ApoE4. So having more like a risk score where ApoE can be included could be the way. And then you can also get this prevention potential. Again, you can't change your ApoE4, but you may be able to modify the modifiable risk factors. And for me, this is the future still, even though we are not yet there with all the answers. Precision medicine, I think getting all the information available from the individual, if it's genetics or lifestyle, modifiable risk factors, omics, this is the direction where we are moving. If I'm thinking the cancer treatment today, yes, they are indeed tailoring the treatment based on the individual risk profiles. So I hope this is the future in the Alzheimer field as well.
Miia, that segues beautifully into what I was going to ask you next. So thank you for kicking off the conversation about personalized medicine. From what you've said, it looks like we have a very thorough understanding of not just the group characteristics and dynamics, but also the individual level, which is going to be the way forward. And I suppose the thing for me is you and I have been in this field for more than a little while together. And periodically, in my case, in the last 35 years, I've been told that there's a blood panel going to be available in 5 years' time. And I think I've heard that about 4 times now. But I get the sense in the last couple of years, with approval rules by the agency for blood biomarkers and other developments, we're maybe inching closer. If you had a crystal ball, how long do you think it would be before we can genuinely say to people presenting in clinic, we know these things about you and we can tailor our treatment to the things we know you're going to need? Is that a 5-year window, a 10-year window, maybe beyond? What would be your best guess?
It's always difficult to predict the future, right? And especially the timeline, as you said. But I think it also depends what type of interventions we are thinking. If we are starting with the finger concept, I think that will happen, and it's already happening, I think, today, and especially I'm thinking the next coming 1 or 2 years. What I mean with that is we are tailoring the multi-domain intervention based on the risk profile. If you have high blood pressure or low physical activity, or if you are not sleeping well, then our advice is try to pay attention, especially on these modifiable risk factors. We can also tailor the multi-domain intervention where you are in the life course. There may be a bit different risk factors when you are at midlife, when you are at late life, if you have early Alzheimer's disease, or if you have more advanced Alzheimer's disease. So that tailoring, I think, is happening and can happen even more, especially when we get more data from the worldwide fingers. The second step, we can start adding medications. For me, it's always the combination therapies that I hope is the future. So we can start adding medications for the modifiable risk factors. We are now, for example, conducting the MedFinger trial when we combine diabetes medication, metformin for the finger to get and see if you can get more clear benefit. Anti-amyloid therapies, yes, if we see that an individual have amyloid in the brain, you could add that medication as well. So I hope that within the 5 to 10 years, we have more medications to be added. And what makes me optimistic, of course, we have the new disease-modifying treatments, but actually 30% of the Alzheimer pipeline is testing repurposed drugs, which are already available today. I mentioned metformin, GLP-1, other type of medications as well. And these are, of course, much easier to start to implement. So for me, it will be a cocktail in the future, individualized cocktail with different kind of interventions, always finger and lifestyle throughout the whole life course, and then you add different medications when needed. So again, I hope if we are here again in 5 years, some of these treatments and individualized treatment options are already used in the clinics.
Excellent. That's a future to look forward to, isn't it? And I'm going to make a little pitch here. Maybe on my 10th series for Pearson of this podcast, we can have you back and we can see how far we've gone with that. But thank you for that. That's a very welcome sharing of the vision. And I think that a virtue of the approach that you and your colleagues have taken to the finger studies is to be very open-minded about how people present with Alzheimer's disease. And it's always a good opportunity to have an expert like you to ask this question of, we've historically been very focused on memory, typically episodic memory, people's recollection of new events. How often do you see people coming into the study who may have memory problems, but maybe their big difficulty is in concentration with language or executive function? Is it very common, or is it quite unusual to see these presentations?
I would say it's very common. We see a lot of issues with other domains, not only memory. And I think the challenge is often that we have been so focusing on memory impairment that we have not been paying so much attention to the other domains, which are really important. If I'm thinking the daily activities in our societies, people need to have the executive function, psychomotoric speed, language. These are often the complaints we hear from our patients at our memory clinic. And also, I'm thinking back to the finger. What we saw was the improvement in the total cognition. We could see 25% more improvement in the total cognitive abilities. But actually, the domains where we could see most improvement was actually executive function. The finger intervention group was improving 83% more compared to the regular health advice group. For the psychomotoric speed, there was 150% more improvement. For memory, we saw 40% more improvement. But this also means that especially the modifiable risk factors, probably executive function and psychomotoric speed, are the domains where we have more improvement or more possibilities for improvement, which I think is very, very optimistic. And one more thing, what we have been reflecting a lot in Sweden, we have changed the name of the memory clinic. They are not anymore memory clinics, but they are cognitive clinics, because we really want to highlight the fact that it's not only memory, but cognition is much broader concept. And that has been actually very well received. And in the future, I would like to focus maybe even more on brain health clinics. We have started this as well, but really pay attention that it's not only diseases, it's the brain health. You can take care of your brain health throughout the whole life course. And there are many factors affecting your brain health. And that may also be easier for the individuals to come to the brain health clinic. There is still a bit stigma around the memory disorders. So I think the concepts and the language we are using are very important. So I think cognition, yes, not only memory, and in the future, hopefully more brain health clinics to give that flavor that you can do something for your brain health. And it's never too late. We know from the finger studies as well, even though we started among at-risk individuals, but the concept works also for patients who have early Alzheimer's disease. And that's why it's very important that these individuals also get support to implement these 5 fingers.
So, and that's a really important message for people to hear, isn't it? It's never too late. It's always worth doing something. So thank you for sharing that with us, Mia. That should be a clear message, I think, for our listeners. And we've already contemplated the impact of lifestyle choices, healthcare factors. We've acknowledged that sadly there's not much you can do about your genes. But we seem to be coming up to an era in which that might change. So I know a topic that's been around at conference, particularly in the last couple of years, in my experience, is trying to exploit our understanding of the genome, maybe even stopping these things at a genetic level before they manifest clinically. Are you optimistic about gene replacement therapies?
Well, again, it's difficult to predict the future, but thinking how much has happened during the last years, and that we now have the tools available and there are interesting studies, I see this as an important, very important field. I mentioned APOE4, and I think that's an interesting starting point because it is it is the main risk factor we know today for the Alzheimer's disease. So I think that's very interesting to see what comes out from these studies. We can take also another approach. I mentioned that the finger intervention can minimize the effect of the genetic factors. So I think the genetic risk can be modified in many ways with the new gene therapy or maybe some drugs or some lifestyle interventions. Maybe all of these approaches are needed. But I think in general, the concept that genes may not be as non-modifiable as we have been thinking, but there are really ways to change the genetic risk is clearly something for the future. And in addition to that, genetics, genome, omics, there is huge development in the field of omics when it comes to proteomics, metabolomics, lipidomics, and now there are these beautiful big data sets globally where you can also use more AI-based models. So I think that can speed up the development in this field.
I agree. And I think one of the really nice developments across the last few years is both the establishment of data sets, which are actually measuring all the things that we believe might be relevant, but also access to them. I mean, that's been a really big development. So I share your optimism. And last year, I dragged myself to an AI, machine learning, and quantum computing meeting and learnt a huge amount really quickly. Probably the most relevant thing was that the architecture for running these machine learning algorithms and running AI on of quantum computing is now apparently within reach, 3 to 5 years, and apparently there will be access to that level of processing. So good cause to be optimistic, I think, but early days, would that be a fair characterization?
I would say so. It's still early days, but giving the competence and data available, I hope we can speed up the development. And also, I'm thinking we need to have new competence like
Mm.
AI, data science, to speed up that development. In that way, I'm really optimistic if we manage to work together. And this has happened. I'm very happy to see that researchers from different fields are coming together and trying really to solve these huge challenges. And of course, Alzheimer's disease is one of those. I also hope we can use expertise from other disease areas, cancer treatment, stroke, cardiovascular diseases. What has happened there? And now, especially the gene therapy and some more advanced therapeutics, I think taking that learning and experience will be very, very important. So that's what I hope for the future, even closer collaboration between different disease areas and new competence, as said, for example, from the AI and data science part.
Yeah, good. That's a wonderful call to arms, isn't it? Let's make ourselves even more multidisciplinary than we have been today. So thank you very much for sharing that. And there's also the job always seems to get bigger, Mia, doesn't it? So my overwhelming experience of the last 35 years is there's always something else to think about. And I think the great revelation for me with regards to risk factors, particularly in the last year, has been the possible role of environmental toxins. So we've understood that, because of changes in climate, we do well to guard ourselves at an environmental level. But I have to be honest, it was a surprise to me to be exposed to the literature suggesting that environmental toxins were actually quite a big risk factor. Could you give us a quick picture of where we are with that, please?
Yeah, that's a great question. And we know the Lancet Commission paper listing the modifiable risk factors, and now air pollution has been recently added to this list of modifiable risk factors. And indeed, there are several studies worldwide showing that long-term exposure to air pollution may increase the risk of cognitive impairment and even dementia. And these are especially the tiny particles which may be increasing the risk. It can go through the cardiovascular mechanisms, but even some direct effects on the brain. For example, these tiny particles may damage the blood vessels. They can increase inflammation. they may cause oxidative stress. And I think that's so exciting that we also start to learn what are the potential mechanisms. From the methodological point of view, it has been more difficult maybe to measure air pollution or maybe heavy metals, at least in our field. Again, we need to work with other disciplines. We are just now involved in two big projects focusing on air pollution and the brain health. And it has been so exciting to learn about the methodology, how you measure the air pollution and what kind of ways you can have to really get closer to the exact measurements. And here, if you compare, for example, measuring blood pressure, of course, we know that methodology much better. So that's why air pollution maybe has been just recently added to the list of modifiable risk factors. So I'm excited about that, and I think there might be more coming there in the future. And another aspect here, I see also that the environment may affect our habits. And this is what we see in the worldwide fingers. Living healthy life, it of course depends what kind of environment we have. Is it easy to be physically active? Is it easy to be socially engaged? Is it easy to eat healthy diet? So here we also need to try to affect the health policy. So it's both the individual level interventions, but also the population-based interventions. And the message is we should try to make the healthy choices the easy ones. So putting together, yes, environment is very important, and we should really think always this bigger level. And we are also thinking more the sustainable planetary health. We try to design our interventions so that they take into account also the planetary health. So that adds a new, very relevant and interesting addition for the interventions.
Great. And your mention of the word planetary reminds me, I was at the Games for Health meeting in Eindhoven earlier this year, and one of our keynote speakers was a physicist who has spent his entire life looking out from the Earth. And in the last few years, he's been looking back on the Earth, and they seem to be finding quite sophisticated methodologies for mapping pollution and the
Yeah.
type of pollution and its density. So again, that appeal for a multidisciplinary approach. It's people in physics now looking very seriously at this issue. So again, hopefully
Yeah.
some rich data we can mine in the future.
Yeah. And I think there is this concept, one health, where we always should think the whole planet in many ways. And this comes back again also for the finger type of interventions, what type of diet we should recommend people to eat. Of course, we always need to think where people are living, that we make it sustainable in many ways as well. So I think this is important to take into account also when we are making our recommendations and having these type of interventions. But affecting health policy is very, very important in many ways.
Yeah, agreed. And you mentioned food, Miia, which is a favorite topic of mine. So
I know that.
so I'm glad we're getting around to it. And I think most people are perhaps a little bit confused about the right approaches to food intake and risk of Alzheimer's disease, but actually other diseases too. So it's quite unusual in the UK for there not to be another newspaper headline about a food that's good for you or bad for you. And quite often 2 months later, the reverse is reported. So it's confusing for people that we're seeking to reach through this podcast. In the UK, we have this expression which is becoming popular that if your grandmother ate it, it's probably good for you. I don't know how much truth there is to that, but it's certainly getting some vogue. And then there's the Mediterranean diet, which you've already been kind enough to mention, and for which I know there is some good evidence that it's a helpful approach in modifiable risk factors. What would be your take on the best diet for reducing your risk of Alzheimer's disease?
That's a very good question, because I would say that the healthy diet is probably one of the fingers that is most difficult to describe and measure. If I ask you, what did you eat 2 weeks ago? Well, it's a bit difficult to remember. So just collecting the data about diet is quite challenging. But also knowing really what's the best diet for your brain is challenging, because we are not only eating nutrients, we are eating the whole meal. So food is quite complex in many, many ways. And now I would say that there has been a movement away from the single nutrients for more the dietary patterns. So for example, what we did in the finger study, we recommended something called healthy Nordic diet. That's what people recognized in our Nordic countries, but it's actually very close to the what we call Mediterranean diet. And this, I think, is the key point. What we know is that many of these healthy diet or dietary patterns, if it's a Mediterranean or Nordic diet or mind diet, they have a lot of similarities. The basis is very much the same. And it's really about getting enough nutrients, what the body and the brain needs. And normally what I recommend, especially for older people, is try to increase the healthy stuff, what your brain needs. And not only taking away something, because sometimes people may think that the healthy diet is so boring and it's very difficult to follow a healthy diet. I don't think it needs to be in that way. Actually, the dietary intervention was the part in the finger intervention where people could have the highest adherence. And I think it comes back to the fact that we tried to be very concrete. We had cooking classes where people could, try different recipes. And you don't need to change everything. You can try to modify your favorite recipe, just adding or replacing some of the ingredients and taking some that is a bit more healthy. So I think what people know that you should eat healthy food, but getting more practical recommendations and some inspiration that you can really cook and eat in a healthy way.
Excellent. That's really helpful. And you intriguingly mentioned that diets not is about adding extra things, not just taking things away. And a field that I've been interested in, I know that you're aware of, is the idea of medical food intervention. And we've not had a lot of activity in the Alzheimer's disease field, but there are products like Souvenaid which seem to have some value. It's available in just a few places in the world, but I think medical foods maybe tend to be overlooked in Alzheimer's disease. Maybe that will change, but then there's that issue of the barrage of advertisements that come at me supplementing my lifestyle with pills and capsules and extracts. As an expert, I just wanted to take the opportunity. If there is a model in which you're deficient, they're useful, I would presume, or maybe we all benefit from a little extra. What guidance could you offer us, please?
Yeah, and indeed, if we are looking the research field, the results have been quite mixed. And this comes back to the fact that there have been different types of trials, different types of interventions, like different supplements and different quality. And that's why the conclusion has been not so easy to really say how much evidence is available. You mentioned Souvenaid, and it's one of the medical foods which we have been also studying. It's an omega-3 based, and it has the important nutrients brain is needing, and it can support the synaptic plasticity. So there is kind of a really strong research base behind that. And it has been studied in early Alzheimer's disease. And again, this I think is the answer. One size does not fit all. You need to know when you need to have different types of medical foods or supplements. So for Souvenaid, we have been testing it in early Alzheimer's disease with positive results. Then we have been combining it with finger intervention, because the idea was that if you have early Alzheimer's disease, it may not be so easy to follow the dietary guidance. And we also know that many Alzheimer patients have lack of important nutrients. And again, in the combination trial, we got very good results already after 6 months, and the experience from the patients was very positive. So this is the hope for the future. Again, more validation and harmonization, but also if you have a lack of vitamin and if you have the risk for that, then you may need that. But just taking it for, for if you're totally healthy, then we don't yet have so much evidence. So for risk individuals, I think that can be the solution. So the same model, you start with the healthy lifestyle and you add medical food, supplements, or pharmacological interventions when needed, based on the risk profile.
That's very helpful, and I think that that's a lovely idea, isn't it? That we've got precision medicine and precision nutrition at our
I
disposal.
love that. Precision nutrition is probably the future. Yes,
That-
yes.
that's I think that's a phrase that we're going to hear a lot in the next few years, and I guess it's nice that we're sort of slowly working towards that. I unusually was a guest on a podcast a couple of weeks ago, and people were asking me about the field of Alzheimer's disease and neuroscience generally, and I heard myself say it's a really exciting time in neuroscience and Alzheimer's disease, and sometimes you've got to hear yourself say these things to really realize for yourself just what remarkable progress we've made and what opportunities seem down the road. So I really think a very exciting time to be doing the kinds of things that you and I've been doing. And I brings us back, if I might, just to some of those risk factors. So on the theme of things that you and I have been to, about 5 years ago, most of the major Alzheimer's meetings that I went to seemed to have a lot of discussion of hypertension, type 2 diabetes, which it was very welcome. But I think much less of a focus on Alzheimer's disease and much more the role of those two things as risk factors. And I guess we've always had this adage, if it's good for the heart, it's probably good for the head, or more typically the brain. Is it really as simple as that, or do you think there's a little more to this issue?
Well, I think we have started to understand that indeed the brain and body are connected
Mm.
and many risk factors are shared for between many chronic diseases. So that connection is getting more clear. Brain is not isolated. Alzheimer's disease is not so different compared to other chronic diseases. Then, of course, we have, as said, now much more evidence, both from epidemiological studies, interventions, but also measures. We can measure much more in an exact way, metabolic risk factors and omics and everything. So science has been leading us to this direction. So I think it's really, really great. At the same time, I would say that we have learned that Alzheimer's disease is very complex, is multifactorial, is heterogeneous. And I think, and many researchers say this, there are several subtypes of Alzheimer's disease. Maybe in some subtypes, there is more metabolic risk factors, cardiovascular, inflammation. Others may have more genetic. So learning this and again, tailoring the interventions based on the risk profile and the subtype, I think will be the future. And maybe finally, I was thinking back to the Lancet Commission paper and the list of modifiable risk factors, which is increasing year after year. There are also novel risk factors like hearing loss, vision, oral health, infection, and inflammation. There are new studies that herpes zoster vaccination might reduce the risk of dementia. So I'm also excited to think that there might be novel ways to reduce the risk, and that nicely comes back to the thing that there are several modifiable risk factors which we can do something about already now.
Mm. Yeah, that lovely to hear that optimism, Miia. And I just another little anecdote. So to my shock and horror, 2 years ago, I developed cataracts, which was something I thought I was way too young to get, but apparently at 63, these things start happening to you. And the remarkable thing for me was when I had them corrected, which was fairly quickly after it was evident I needed lens replacement, as well as giving me the best vision I think I've ever had. I also had a very profound behavioral response to this. I felt very euphoric, even to a point where I asked people in that business, is there any evidence that a different receptor of light coming in through your lens and onto your retina changes your brain chemistry? And they said there's at least a good hypothesis. So I think that idea, we tended to box things up, haven't we? We sort of said we're going to look at this today, but that idea we might bring it all together really starts to beg, and I guess with big data sets, there's that opportunity, isn't there? We can let loose these new technologies and new approaches, and maybe things will pop out that will both delight and surprise us.
Yeah, yeah. And again, these are simple or relatively simple interventions. Hearing, again, the same thing. I
Mm.
hear the story for many older people when they get the hearing aid. is life changing. So it can really kind of affect so many other factors as well. If you hear, you are more socially engaged, you may want to be part of different things. So that can really, really help. We have just started a new trial called HAHA. Healthy hearing for healthy aging. And that's a trial to really try to understand how individualized hearing aid can affect the cognitive decline and what are the underlying mechanisms. So I think it's just an exciting example that we are still also learning a lot of the single novel interventions which we have been now talking about. And what we do already now, I say that the fifth finger is cardiovascular metabolic risk factors. At our brain health clinic, we have been adding hearing and vision and oral health as part of the fifth finger. So it's more now the holistic care.
Ah, all right. I love that you seem to have cornered the market on very engaging acronyms, Miia, you and your team. So the HAHA study, delighted to hear that. And of course, very good luck with that. That's a very intriguing prospect. And given we've come to this with such optimism, we've talked about so many different things, this next question feels maybe a little bit unfair. But just in terms of your own experience, if I asked you to reflect over the last 5 years, was there one breakthrough or maybe one development that you think was really, really important for our field?
Well, I think I may need to point with five fingers at least, not only one, because to be fair and given how complex Alzheimer's disease is, it would be, I could not say that there is only one discovery. There have been small steps in different fields, both prevention and risk reduction, but also early detection. Who could have believed that we will have blood-based biomarkers available? And that's now where we are. And treatments, that has been difficult, but now we start to see many new disease modifying treatments. And also, I mentioned already the repurposed drugs. And for me, if we manage to put together all these three different areas, then we can get the largest benefit for the individuals and for the societies. Normally, it takes at least 15 years to start to implement the research findings. I think it's a bit too long time. We know how big challenge Alzheimer's disease is in our societies. I think we need to speed up and we can speed up the implementation. So what I would like to see now is more implementation and implementation science so that we really can make sure that these wonderful research findings can really benefit our societies.
Mia, thank you for such a fascinating and thought-provoking discussion. I always admire the enthusiasm and passion that you bring to this topic, and it's always a delight to hear you outline these things so eloquently. Your insights help us gain a better understanding of the complex factors that can lead to Alzheimer's disease and offer us a sense of agency and, most importantly, hope for those looking to prevent or delay its onset. Thank you so much for joining us today.
Thank you. My pleasure.
Thank you also to our listeners for joining us. In our final episode, we'll explore the potential of early diagnosis through biomarkers and emerging technologies. I'll speak with Dr. Rhoda O about how tools like cognitive testing, blood-based biomarkers, and even digital gameplay could revolutionize the way we detect and monitor Alzheimer's disease, and potentially long before symptoms appear. Until then, thank you for listening to the Progress Profile, Alzheimer's Research in Focus.